So maybe you don't have Cushing's disease, but maybe you have high cortisol levels because of excessive stress. We already talked about some of the physiologic effects of that excessive cortisol, but what sort of things, like larger overall disorders, might that lead to? Well, let's go with some of the individual signs. High blood pressure. Can high blood pressure over a long period of time lead to other conditions? Cardiovascular disease, right? So increasing the risk for cardiovascular disease. What else does it elevate besides blood pressure? Elevates blood sugar, right? It's a glucocorticoid after all. And prolonged elevated blood sugar is, of course, a risk factor for what? Diabetes, right? So we also have depression of the immune system. Might leave you more open to, infections or other diseases. Depression of the immune system also puts you at greater risk for more serious things like cancer, for example. So it's probably true that stress and excessive cortisol levels on their own probably aren't enough to give you cardiovascular disease, diabetes, or cancer, but it will increase your risk for each of those things. Also in here is hyposecretion, not enough cortisol. That's called Addison's disease. So if you don't have enough cortisol in your system, what are some things? It's sort of the opposite of Cushing's disease, right? So if Cushing's disease results in excessive fat deposition, people with Addison's disease would probably tend to be
losing weight.
Thinner, right? Yeah, losing weight. And I don't have a good explanation for this other than I just know it's one of the signs of Addison's disease. It also tends to create a bronzing of the skin. So at first, this kind of sounds like an awesome disease to have, right? Makes you thin and tan. But there are other problems with it too. Since cortisol helps regulate your blood pressure, Addison's disease has excessively low blood pressure associated with it, and you can be looking at things like fainting spells and that kind of deal. Addison's disease is defined as a hyposecretion of cortisol, but we also usually have a concomitant decrease in mineral corticoids too. So not enough aldosterone, and you can affect sodium levels and again pressure. Just as kind of a little historical note, President Kennedy had Addison's disease. And a lot of the pictures are in black and white, so you might not notice it, and you might not even really think about it if you look at one of the colored photographs, but JFK was a redhead. He was kind of a ginger, and yeah, maybe you never thought about it, but he was kind of abnormally tan for a redhead. And one of the reasons why is because he had Addison's disease, and it caused a tanning of the skin. And this didn't really come out until after his death, but to treat his Addison's disease, he had to take injections of glucocorticoids. As we saw, that tends to weaken connective tissues like cartilage and bone. He had suffered multiple compression fractures of his spine before he died, and he died a young man. He was in his 40s, but he had had multiple compression fractures like a 90-year-old with osteoporosis as a result of the treatment of his Addison's disease. And then finally, the bottom layer of the adrenal cortex, which is the zona reticularis, produces what are called gonatocorticoids. And those are simply sex hormones like, and especially, androgens, which are testosterone. Now, of course, normally when we think of testosterone, we think of it as being made where?
Testes.
In the testes. And in males, that is really true. However, do females have some testosterone in their body? Sure. But they don't have any testes, right? So, where's it coming from? Well, the answer is here, from the bottom layer of the adrenal cortex. So, what is the function of these gonatocorticoids? Well, it's responsible for the production of testosterone in people who don't have testes to produce them in. So in females and in prepubescent males too, because although they have testes, they haven't begun producing testosterone there yet. Okay. Although testosterone is not the dominant sex hormone in females, obviously, it does have some roles to play. So, for example, sex drive in women is at least partially determined by androgen levels, and that's produced in the adrenal cortex. We think that it may play a role in the onset of puberty too. So, obviously in males, the majority of testosterone is produced in the testes, but levels from the adrenal cortex may play a role in jump-starting that whole process. And in postmenopausal women, this layer of the adrenal cortex can also produce estrogens. And again, the ovaries normally do that, but after menopause, they don't anymore. So estrogen levels that remain are probably coming from this layer of the adrenal cortex. It says here appearance of secondary sex characteristics. That would only be true in an abnormal situation, not under normal conditions. So we haven't really talked about it too much yet, but now would be a good time to start, and it will come up a couple times through the remaining part of the semester. What are secondary sex characteristics?
It's like after puberty, right?
Mm-hmm.
Facial hair in males and
Right. So secondary sex characteristics are things not directly related to reproduction, but physical characteristics typical of a specific sex. So you mentioned facial hair in men. That would be a male secondary sex characteristic. Breast development would be a female secondary sex characteristic. Things like that. Okay? Now the reason why I say that the gonatocorticoids are probably not leading to secondary sex characteristics is because they just don't make enough of it. So in males, yes, it's a result of testosterone, but as you pointed out, those things don't appear in males until puberty, right? When the testes begin producing this stuff at a much higher amount. So in order for the gonatocorticoids from the adrenal cortex to produce those results, you would have to have something, as I said, abnormal, a hypersecretion. There's something called adrenogenital syndrome, which is the production of too much testosterone by the adrenal cortex. Now, obviously in adult males, this is not really a thing, right? Because we're supposed to have high levels of testosterone. And so it's not a problem. But this can produce undesirable effects in children and in females at any stage. Basically people who aren't supposed to have testosterone levels that high. It results in a masculinization effect, which basically just means development of male secondary sex characteristics inappropriately, either in a young person before its time or in a female at any stage. What are secondary sex characteristics of the male that might start to show up? We mentioned facial hair development, but not just the face, right? The body hair too. What else?
deeper voice.
Yeah, a deepening of the voice, or maybe I should say a deepening of the voice. Like we pointed out last time, or not last time, in a previous chapter, in the respiratory system, the size of the larynx, the thyroid cartilage and the vocal folds contained within it, is affected by testosterone levels. So if they go up, you have a larger larynx, larger vocal cords, deeper voice as a result. So beard, body hair, we talked about a deepening of the voice, possibly an increase in aggressive behavior, though not necessarily. And I like how they just drop this one in there at the end and be like, okay, let's put that in and move on. And your clitoris looks like a penis. So on to the next thing. Like, wait a minute, what? Okay, so let's explain that. We will talk about this more in the reproductive system, obviously, but although male and female reproductive systems have two separate sets of anatomy, they originate from the same place embryologically, right? So prior to about 16 weeks of development or so, there's not an anatomic difference between male and female, okay? Meaning we all start with kind of the same tissues. But around that time, a male fetus will experience a rise in testosterone levels, causing it to turn into male genitalia. Female fetuses don't get that, and it transitions into female genitalia. But the reason why I point all this out is because they do come from the same tissue, so they have the potential to be sensitive to the same hormones. But in females, you just don't generally get that hormone rise, unless you do, right? And the clitoris in females is made of the same stuff, basically, as the penis in males. Now, it never grew in embryologic development because there wasn't that rise in testosterone levels. But if there's an increase being produced here in the adrenal cortex, it can respond in the same way that the penis does. Initially during fetal development, and then a similar sort of boost later on during puberty. And it can respond to that and grow and, yeah, begin to look like a penis. I was watching some stupid reality show one time years ago, and there was this woman who had been a female bodybuilder. She wasn't anymore, but for her success in bodybuilding, she did a lot of steroids, including testosterone, and she was having a plastic surgery known as a clitoral reduction because she experienced the same problem, not as a result of the adrenal cortex, but taking it as a drug, right? But the clitoris grew to almost look like a penis. She said that it, when erect, was about 3.5 inches long, which is terrifying. I believe they call that nightmare fuel. And then we get down to the adrenal medulla. In the adrenal medulla, we've got a totally different scenario going on, okay? So the adrenal cortex is controlled hormonally. The adrenal medulla is controlled neurologically. The adrenal cortex is producing corticosteroids. The adrenal medulla is producing epinephrine and norepinephrine, which together we know better as adrenaline, right? They have some of the effects of adrenaline listed there, but I think most of us are probably familiar with it. Increased heart rate, increased blood pressure, sweating, nervousness, increased blood sugar as well, right? All of those things are potential effects of the adrenal medulla. Compared to other hormones, its response is pretty brief, but it also tends to be pretty dramatic. This is a hormone that you feel the effects of pretty clearly. You can, like the other ones, have too much or too little of it made. Hypersecretion of the adrenal medulla can sometimes be a result of a specific type of tumor called a pheochromocytoma. We've seen that tumors of various kinds of glandular tissue result in overproduction, right? But what's kind of unusual or unique about a pheo is that its excessive release of adrenaline tends to be sporadic, not consistent. So there can just all of a sudden be a big adrenaline dump into the system for no reason. So, that feeling that you get at the very top of a roller coaster, or when a cop pulls up behind you on the road, right, can just appear out of nowhere in something like this. So you see there, hyperglycemia, too much blood sugar, rapid heartbeat, possibly palpitations, high blood pressure, nervousness, sweating, as a result of the excessive production of adrenaline. It is possible to have a hyposecretion where the adrenal medulla does not function properly and you don't get that adrenaline in situations where people otherwise normally would. It says here it's not problematic. That's probably true for almost everybody, especially these days. Now, this could have been a problem in, say, our more primitive ancestors, right? Because our adrenaline, our fight or flight response, is designed to help us avoid a threat. Now, in us, it kicks in most of the time in other situations, right? So a hyposecretion of adrenaline probably doesn't have any major consequences anymore. Here in this slide, we're comparing and contrasting mechanisms for the adrenal medulla on the left versus the adrenal cortex on the right. So the adrenal medulla, right here you see that's innervated by sympathetic fibers, like we mentioned, fight or flight. So these sympathetic neurons innervate the medulla, and it produces adrenaline with all of the effects that we mentioned. For the adrenal cortex, it begins in the hypothalamus that makes CRH, which causes the anterior pituitary to make ACTH, stimulating production here in the adrenal cortex. Things like aldosterone and cortisol and gonatocorticoids. Next gland on the list is the pineal gland. You might remember this one because it's actually found in the brain. So at the end of AP1, when we did the sheep brain dissection, the pineal gland was one of the structures that we identified. The pineal gland produces melatonin, which can circulate as a hormone, which is why we're talking about it here in the endocrine system. It's also used as a neurotransmitter in the brain. Melatonin makes you sleepy, right? Melatonin is involved with sleeping. But more important than just helping put your brain to sleep is establishing your sleep-wake cycles, your circadian rhythm. So the periodic and predictable release of melatonin is important in this, what we call circadian rhythm. The things that occur in your body at specific times of the day, your body clock, so to speak. So this can be important in helping to regulate the release of ACTH like we talked about before, and cortisol that goes with it. But besides simply your day-night cycles, or you can look at it this way, yes, it helps establish your body clock, but it also helps you judge time longer than that. Maybe you could say your body's calendar, right? And things that occur at specific times in your life, your body and your brain can estimate how much time has passed and whether or not it's appropriate to do these things by establishing this timing through the periodic release of melatonin. So you see there, timing of sexual maturation and puberty. The estimation of how old you are can be derived from the periodic release of melatonin. And you could also put in there then, besides the onset of puberty in females, also the onset of menopause, which occurs at specific times during your life. Next up is the pancreas. As we mentioned at the beginning of the chapter, the pancreas is both an endocrine as well as an exocrine organ. So in the last unit, when we were looking at the digestive system, we saw its exocrine functions, the production of pancreatic juice. But the pancreas is also producing at least two important hormones. The endocrine function of the pancreas is occurring in these little places called pancreatic islets. So you would see these microscopically, but these are little collections of cells within the pancreas responsible for the hormone production. Here's a picture of a pancreatic islet. The two major cell types in there are alpha cells, which are these darker colored ones, and beta cells, which are the lighter colored ones. The alpha cells are producing a hormone called glucagon, and the beta cells are producing a hormone called insulin. I would imagine that probably almost all of you have heard of insulin, but maybe not necessarily glucagon, although they are both important. Insulin and glucagon are the primary regulators of what?
Blood sugar?
Blood sugar, yeah. We've seen other things that can affect blood sugar, like epinephrine and cortisol, but the things that are most often responsible for regulating blood sugar levels are glucagon and insulin. So what type of stimulus do you think these are responding to for their release? Hormonal, humoral, or neural?
Is it humoral?
Humoral. They're responding directly to levels of sugar in the blood. So for example, glucagon's major job is to increase blood sugar levels. So if you're the pancreas sitting around there, blood sugar levels start to drop. You respond directly to those levels in the blood by releasing glucagon to bring them back up. So if it's been a while since you've eaten, you've used up all of the energy that was in your bloodstream from the last meal, okay? And now you're starting to run on E, so to speak. Your blood sugar levels drop, glucagon is released to help bring that back up. Well, how can we How can we do that? What do we do to elevate blood sugar levels? Two major things: glycogenolysis and gluconeogenesis. This word lysis, what does that mean?
Like, is it breaking it down?
Yeah, breaking it down. And then this first one here is glycogen. What's glycogen?
Sugar?
Close. It's a complex carbohydrate, okay, made up of sugar subunits. So when we break that down, we get sugar. Glycogen is found in most of the cells of your body, but it's found in the highest levels in your liver. So there in the liver, glycogen gets broken down. You wind up with free glucose to go in the bloodstream and help bring it back up. Gluconeogenesis, also happening, refers to the production of glucose from non-carbohydrate sources. So what kinds of things can we also use as fuel besides carbohydrates?
Fat.
Fat, right? And also proteins. The way that we get energy from those things most of the time, we'll see an exception in a few slides, but most of the time we're not burning those things directly, but rather converting them into glucose through this process of gluconeogenesis and then using that for fuel. Okay? And again, that's a result of glucagon. Insulin is the antagonist to that. So if the job of glucagon is to bring blood sugar levels up, the job of insulin is to bring them back down. That's right. So when you consume a meal, especially one that contains a lot of carbohydrates and those sugar subunits get absorbed into your body, sugar levels rise. Then the pancreas responds by releasing insulin to bring them back down. One of the most important ways that insulin brings sugar levels down is by allowing the glucose to enter cells of your body. So a lot of the cells of your body actually can't take in glucose unless insulin is also present. There's some exceptions, as you see here. The brain and liver, they always can take up the glucose. But a lot of the other ones, they're mentioning fat and muscle, for example, they require insulin. Think of insulin as the key that opens the door, right? This morning when you guys arrived here before I did, you couldn't come into the classroom because the door was locked, right? And then when I got here with the key, I opened it and we were able to come in. Think of yourselves as little glucose molecules entering a cell. You can't enter unless insulin unlocks the door for you, okay? And when this sugar enters the cell, not only does it provide those cells with energy, but it also helps to bring the levels in the bloodstream back down. Now, what are some, let me take a step back. Is it possible that blood sugar levels can go too high and that causes problems? Yeah, that's one of the reasons why we need to lower it. What sort of problems does too high a blood sugar cause?
Oh, your brain function?
It can affect the way your brain functions, sure. What about long-term effects? You guys are probably familiar with diabetes, right? What are some things that in diabetes, one of the main things that's happening is blood sugar levels remain too high, right? What are some problems that diabetics can face long term?
Feet swelling up?
Yeah. Nerve damage, right? Tissue death sometimes. And we'll talk about that a little later on. Actually, let's go right to it. This is called diabetes mellitus. Now, we talked about diabetes insipidus a little bit before, but remember that's unrelated. Diabetes insipidus is a deficiency of a particular hormone. What hormone would that be?
Insulin or
Not for diabetes insipidus.
the other one.
Yeah. That's a deficiency of ADH that concentrates here. But here in diabetes mellitus, we're looking at a problem with insulin. Now, you guys are probably aware that there are a couple different types of diabetes mellitus. We talk about type 1 in type 2, which they're describing as a hyposecretion or a hypoactivity, which basically means in type 1 diabetes, the problem is you're not making enough insulin. In type 2 diabetes, the problem is you are not sensitive to the insulin. So type 1 diabetes mellitus often involves a problem with the pancreas. And in case you're wondering or you've heard these terms before, we used to refer to type 1 diabetes as juvenile diabetes and type 2 as adult onset, but type 1 and type 2 is a better way to refer to it because, first of all, type 1 diabetes does not have to occur in childhood. I've known more than one person who acquired type 1 diabetes in adulthood. It does happen. And secondly, we've gotten really, really good at making our kids fat and giving them type 2 diabetes in childhood. So it's no longer simply just juvenile. I've heard of cases of type 2 diabetes in children as young as 9,
I had
which
a
is,
friend who did that.
which is to me like borderline child abuse.
It was in the South, and she was
Yeah.
a big girl, and they deep fry everything.
Yep.
Her kid.
So in type 1 diabetes mellitus, again, the problem is with your pancreas's production of insulin. So this can be due to damage to the pancreas. Both of the people I knew who got type 1 diabetes as an adult got it from a virus that attacked their pancreas and was permanently damaged, and the production of insulin was inadequate as a result. Type 2 diabetes is a little bit more complicated because, again, it's a problem with insulin sensitivity. This relates to something we talked about in the beginning of the chapter, upregulation and downregulation of receptors. So remember, if levels of something remain high, too high, cells of your body will start to decrease the number of receptors to it in response. So type 2 diabetes is often related to diet, right? If you eat a bunch of junk for a long time, sugar levels remain high, which means insulin levels will be high too, trying to bring those back down. Well, insulin's a hormone, and if levels of that hormone are too high, you will decrease your receptors and become less sensitive to it. The problem is, if you're still eating like that, now with less sensitive insulin receptors, those sugar levels are not being brought down effectively. And as we mentioned, maintaining sugar levels that are too high for a long period of time has permanent damaging effects on things like nerves and capillaries. So that can be a problem.